everyone. The topic of this lecture is implant supported crown and bridge, which is a new topic that has been included in the syllabus this year. So let us move on. So before we go on any further, let's review certain rationales for the using implants as a restorative choice and the various terminologies most commonly. So the goal of modern dentistry is to restore patient to normal, function, aesthetics, comfort, and speech. What makes implant dentistry unique in this ability is that regardless of the atrophy of the oral system or the oral musculature or the regardless of the disease, the type of injury, uh, implants can still be placed. Okay, the number of implants placed all over the world has increased tenfold from 1983 to 2002, and another fold from a five-fold from 2000 to 2005, and it's still growing. Okay, so for example, these are some of the most statistics of the implants that are being used uh, per capita in various developed countries. We can see here Israel is leading with the most number of implants placed per 10,000 of the population, and among this list, last in the end, we have Canada and Australia with over 40 implants being placed per 10,000 of the population. I think this also depends a lot on the affordability of the implants. As we know, all the developed countries like US, Canada, Australia, they and the UK and the Europe, the implants are pretty expensive, and because of that, not everybody can afford them unless it is being insured by the insurance provider. Whereas countries Southeast Asia and countries like Israel and all, which have a lot of the implant manufacturing companies, so the cost is much less and much more affordable. So this is the same thing in paragraph format. The percentage of teeth that is being replaced with an implant in countries such as South Korea, Israel, and Italy is 30 to 40%, which is a huge chunk. That means out of every 10 teeth that are being lost, 3 to 4 teeth are being replaced by implants, which is a very encouraging number. Whereas in the United States, only 1 out of every 10 teeth is being replaced by implant, that is around 10%. Okay. So among the Korean implants, Ostem is the major provider for the implants, followed closely by Megagen, Dio, Neobiotech, and Dentium, which are all among the pioneer implant companies popular worldwide. Okay, because of the increasing demand of the, why is there an increased demand of dental implant? One is because of the excellent health care and medical care facilities and the insurance providers. First of all, the patients are living longer due to a better quality of life. So obviously, when the patients are living longer, they will tend to lose their teeth, and hence the demand for implant. Secondly, due to age-related losses, like I just mentioned, when the teeth are lost, patients often demand a fixed replacement instead of a denture. And nowadays, the older individuals, older senior citizens are more socially active, and they are more socially conscious as opposed to previously. And of course, because of the conventional processes complication, regardless of how good a fixed partial denture or a crown or a cast partial denture you give, every restoration in the mouth is subject to wear and tear and the environmental factors. So this will ultimately result in their failure at one point fine day. Okay, and of course there are the inherent advantages of implant supported restorations. Okay, so now what are the anatomical consequences of edentulosum? I am sure we all have read about residual ridge resorption in the year 3 and year 4, and we all know that when the teeth are lost, the residual ridge resorption is a continuous and ongoing phenomena which cannot be stopped, regardless of patient receiving a removable partial denture or a complete denture or a single complete denture. The bone loss of the residual ridges is inevitable, and it keeps continuing throughout the life of the individual. That is till the day the individual is going to die. RRR is an ongoing phenomenon, although it slows down a lot after the first year. But with the placement of implants, the RRR residual resorption can be arrested to a greater extent because of stimulation to the bone. Because when the teeth are present, the bone receives the stimulus in the form of a stress and strain, which helps in bone remodeling and the maintenance of the bone levels. But when the teeth are lost, the same thing causes the resorption of the alveolar ridges, and that's why we see that patients who have been edentulous for say 15 to 25 years, they have paper thin mandibles or severely atrophied maxillas. But when implants are placed in this situation, instead of a denture, you place an implant, then these implants offer the stimulation needed for the bone remodeling and the bone maintenance. Okay, so this will in turn arrest the bone resorption or the residual ridge resorption and help in stabilizing the residual ridges. Okay, now in year 4 also you had an introductory lecture on dental implants, but we'll quickly brush through. So among the endoceous implant is an implant which is placed within the alveolar ridges, okay, inside the bone, inside a bony envelope. We have mainly two categories, that is the root form implants, or the which are also known as screw implants or the cylindrical implants, and we also have blade implants. Now blade implants are very rarely used nowadays, more or less they are not being used nowadays. So the most common implant is your screw form or the root form implant. Okay, because blade form implants had a very low survival rate of 5 years, which is not really acceptable or a realistic expectation to be given to a patient, whereas the screw implants or the endoosseous implants are the most widely and the most successful implants worldwide. Okay, so in this previously we had tapered cylindrical core vent implants which were which had to be tapped into place. Now we have the screw shaped self tapping implants. Okay, so an implant typically consists of the implant body, okay, or how we know it over here as the fixture, which manufacturers refer to it as a fixture, which is goes inside the bone. It's a root form implant, and then over which we have an abutment screw which retains the abutment. Okay, and the implant has various design features which are known as the collar, the micro threads, the macro threads, which can be of different shape, buttress threads, square shaped threads, reverse buttress threads. Okay, so moving on, there are basically two types of implants broadly. One is the what you call as the bone level implants. As the name suggests, these implants are placed flush with the crest of the alveolar ridge. So this is a completely rough surface implant, and they cannot be placed supracrestally. So the implant collar should be flush with the bone level. If it is placed supracrestally, it can promote the plaque accumulation, bacterial colonization, and ultimately peri-implant mucositis and later peri-implantitis also. Okay, the next type is an implant which is known as a tissue level implant. Now tissue level implants have a polished collar of about 3.2 to 3.6 mm. So this polished collar can be placed within the gingival sulcus, or within the gingiva peri-implant tissues. So these are the opposite of bone level implants. Here the polished collar should not be placed subcrestally, as the bone cannot bond to the polished collar and it can result in the bone loss around the crestal portion of the implant, later resulting again in peri-implant mucositis or fracture of the implant due to bone loss. So the tissue level implant, the polished collar is always placed within the tissue contour, that is trans tissue. Okay, so both of these implants have certain indications and for situations in which they will be used. Okay, so here the abutment and the implant interface is much away from the bone in terms of tissue level implant, so this is more favorable to the periodontium and with less chances of the peri-implantitis. Okay, now coming to the prosthetic restorative options, that is, what are the different restorative options available for us for restoring the implants. Okay, so Kalmish had given a classification which is broadly agreed upon and followed all over the world. This classification is depending on the type of the prosthesis. So basically, this classification we have three fixed options and two removable options. So fixed options are known as the fixed prosthesis 1, 2 and 3, and the removable options are known as RP4 and RP5. Okay, this depends upon the volume of the tissue that is being replaced by the restoration. That is, if a restoration is replacing only the coronal portion of the crown, of the clinical crown, in an healthy individual with minimal to no bone loss, it is known as the FV1 prosthesis, which is the most ideal and most aesthetic type of prosthesis. Whereas the second type is an FV2 prosthesis. You can see over here. So an FV2 prosthesis replaces the clinical portion of the crown and a portion of the root. Like normally with age or due to periodontitis, with the recession or the bone loss, some amount of the cementum is exposed to the oral environment, okay, and resulting in a greater clinical crown with age, progressive age, or due to other factors, okay. So an FA2 process is a process which replaces the crown and a portion of the root also. Whereas an FE3 process is a process which replaces the crown, portion of the root, as well as a portion of the gingiva to maintain the pink aesthetics. Okay? So this on the left hand side is an example of FE1 processes which replaces only the clinical crown of the tooth. That means there has been minimal bone loss vertical or horizontally in a young individual, whereas this is the FE2 type of process which is replacing the crown and a portion of the root also. Okay. Next, as I mentioned, FP3 processes, since it replaces the crown and a portion of the gingival tissue. So it's mainly like a denture which replaces the teeth and the soft tissues as well. So there we can have different type of processes. We can either have hybrid processes which is made of from the PMMA, pink colored PMMA, and the denture teeth. So this is basically, in simpler terms, a hybrid process is a fixed denture. Okay. And second, we have an option nowadays very popular is the monolithic zirconia, which is a milled complete single block of monolithic zirconia, which is then layered with pink feldspathic porcelain to replace the gingival tissues. Okay, this is done when a lot of alveoloplasty has been done, or there has been extensive ridge resorption, or there is excessive interalveolar interarch space. In such cases, we need to give a FE3 type of processes. Okay, and the third option, a very popular option, is the PFM processes, in which first a titanium or the chrome cobalt bar is fabricated over the implants, and over this the ceramic is layered. Usually feldspathic porcelain or glass ceramics are layered on top of it. All these three are excellent options. Hybrid processes are much cheaper and very popular among patients, and can easily be replaced anytime. Okay. Next, we are going on towards the removable options. In removable, as I mentioned, there are two options: RP4, that is removable prosthesis 4. This process is more or less like your tooth supported over denture. But this process does not take any support from the soft tissue or the musculature. It only takes support from the bar in the form of the O-ring or locator attachment or any type of clips. Okay. As an RP5 process is your classic overdenture, which takes minimal support or anchorage from the implants, but majority of the support is from the basal denture seat area. Okay, so you can see over here there are 4 implants placed over here in the first molar and the second molar region, and these are only enough to anchor the process in place, but the majority of the support and stability is achieved from the denture basal seat area. So this is a classical overdenture, in this case an implant supported overdenture prosthesis. Okay, and very economical and serves the purpose. Now coming to different type of restorations for crowns and bridges. Now restorations by the full arch or a single tooth restorations can be either screw retained or cement retained restorations on top of the implant. Okay. So screw retained crowns look something like this. These are monolithic zirconia crowns which are screw retained. That means there is no cement involved, like how we cement the crown or the bridge on a tooth. Then we have our cement retained implant, which are similar to conventional crown and bridge. That is, the abutment is a separate part from the crown. First the abutment is screwed into the implant, and then the crown is cemented on top of the abutment. Okay, these abutments again, just like crowns, can be all ceramic or metal based or alloy based abutments. These can be stock abutments or customized abutments, like in this case this is a customized titanium abutment, and this is a customized uh, zirconia coping cemented on top of a stock abutment or the tie base. Okay, and then the crown is separate. So these are cement rated because the crown is cemented on top of the abutment. So both have their own advantages and Like the factors that affect the choice for selecting a screw retain or cement retain depends on the method of fabrication, ease of fabrication, the complexity, the cost factor, the access, the type of occlusion the patient has, whether it is heavy occlusion or light occlusion. Okay, and depending upon whether we want the restoration to be retrievable and the incidence of loss of retention, various factors are there. Okay, so we'll cover some of the very basic factors which are most commonly encountered. So first is retrievability. When we want a restoration to be retrievable, that is in the future we should be able to easily take it out anytime for maintenance, for any other issues, or for replacing the crown with a more better crown. So in such cases, a screw retained crown is the restoration to go with, because they can be easily removed without any issues just by torquing and untorquing the screws. Okay, or whenever we think that in future there could be incidences of screw loosening or screw fracture, then we should go for screw retention. Okay, so whenever there is screw loosening or loosening of the crown when the patient comes in those cases, we can easily access the screw hole and retighten the screw in place. Okay, so this is one of the reasons why screw retained monolithic zirconia crowns are a very popular option. This is a Ostem ebony screw and a Ostem transfer abutment, and over which a monolithic zirconia crown has been made. Okay. Also, like I mentioned, because when screw fracture or screw loosening happens, it is easier to remove a screw retained crown. But of course, if you have an implant neck fracture, like in this case, then it is totally non-retrievable. In such cases, you have to place a new implant. Next is the effect on peri-implant tissue health. Now, screw retained crown again are the most preferred option when there are concerns of the peri-implant tissue health in the future, because since there is no cement involved, so there is no chances of any cement getting trapped within the gingival sulcus and causing later peri-implant mucositis. Okay, so we can see over here when we have a stock abutment like this, which is docked on top of the implant, and then if we say cement a crown, then the cement escapes into the peri-implant tissues. Okay, and this cement, if not removed, can induce peri-implant mucositis later on. I'm not saying it will, but there are chances that it can. So in such cases, we have to use a plastic instrument or the Teflon scalers, hand scalers, to remove the cement, but it's not very easy. We can use an abutment with an end line. Usually abutments are with no end line or no finish line, and abutment with finish line as over here. So advantage of using abutments with finish line is that the cement moves in a more lateral direction and then the gums will push it outside. So in such cases, it's always better to use an abutment with the finish line, or we can tell the lab to fabricate or trim or mill a finish line on top of a abutment. Okay, but still it's always preferable to use a screw retained crown in such cases, but sometimes in anterior situation and all, we prefer to use a cement retained crown. Again, when we have such a deep vest sulcus, like a 3 to 4 vestibule gingival tissue thickness over the implant, then it is very difficult to remove the cement in such cases. So in such cases, it is always better to use a screw retained crown, even though it is an anterior crown. If we properly use a good restorative material like composite and finish it properly, then the hole is very difficult to detect. Okay, and now third is the immediate loading. So when we are planning for immediate loading, or the patient demands immediate loading, and we have good primary stability, we can give immediate loading. Such cases also, again, screw retained restorations are more preferred because they eliminate the need for cement, and placing and removing is easier. Okay. Next is the incidence of porcelain fracture. Now, this is a disadvantage of screw retained crown. The incidence of porcelain fracture or chipping is more common with the screw retained restorations. This is because the in porcelain around the screw access hole is usually unsupported, and if the patient has a heavy occlusion or occlusion at the junction of the porcelain and the restorative material, then this can result in chipping and fracture, or if the occlusion is not properly adjusted at the time of fixing of the crown, then these things can happen, and it is not a desirable outcome. So in some cases, if we want, we can give a cement retained crown, or we could use a monolithic zirconia crown like shown over here. So monolithic crowns usually are not layered like your PFM crowns have a layer of metal, then a layer of opaque porcelain, then a layer of body porcelain, then a layer of your incisal or enamel porcelain. So there are no layers in this. This is milled from a block of pre-sintered zirconia. Okay, so the less chances of fracture and chipping with monolithic zirconia crowns, because they are very bulky and solid as opposed to the crowns made on natural teak. Okay, so that we can use these crowns. Otherwise, also the advantages are, like I said, there is no cement space between the abutment and the zirconia, so there is no micro gap. There is no cement in the peri-implant tissues. It is one solid piece, so less incidence of chipping, and it is easy handling because there is no cement involved. There is no cleaning involved. Okay, so they are more easy. Now coming to vertical restorative space, especially in the posterior dentition, this is of concern. When we have insufficient vertical restorative space for the crown or the bridge, then a screw retained crown is more preferable because we require less height for a screw retained crown, whereas for a cement retained crown we need a minimum of 7.5 mm ideally. Okay, because in screw retained crown usually are made on tie bases or customized bases which have a very low platform of 0.2 mm or 0.3 mm, and height can be kept at minimum 3 mm, and the ceramic is built up over it or is glued on top of it. Okay, whereas cement retained crowns, the abutment has a shoulder or collar of 2 mm, then a 4 mm height, then minimum of 1.5 mm from the cement retained crown, so we need 7.5 mm of vertical restorative space for cement retained crown. Okay, so these are the most common factors that determine selection between screw retained and cement retained crowns. Although in the anterior zone, cement retained crowns are the most aesthetic crowns, and they are also more expensive because when you are using customized zirconia or alumina or customized titanium abutment, so they also become more expensive than the screw retained crowns. So these are all the factors. And in conclusion, implant supported crown and bridges offer several benefits over traditional options such as cast partial dentures, traditional crowns and bridges, over traditional tooth supported or the complete dentures. But they provide aesthetic, surety, functionality, longevity, and confidence. While the process of getting these may take several months, the end result is durable and long lasting. Proper care and is however very essential in terms of any restoration, not only implant restoration, but with implant restoration, proper meticulous follow up checkup is very important. Okay, that's it.